And good evening, everyone, and welcome to the Oculus Clinical Webinar Series. I'm really excited tonight to have Dr. Stephen Greenstein present Streamlining Cataract Evaluations, Enhancing Workflow for Pre- and Post-Operative Efficiency with the Pentacam AXL Wave. Before I introduce Dr. Greenstein, a little housekeeping. Number one, any questions you have can be put in the chat, and we'll leave some time at the end to answer your questions. Additionally, if you want to review this broadcast, it'll be available in approximately 1 week via an email link sent to you. Dr. Greenstein is a graduate of Harvard Medical School, Corneal Refractive and External Disease Fellowship in Massachusetts Eye and Ear Infirmary. He's currently the medical director at the Cornea and Laser Eye Institute and the CLEI Center for Keratoconus. He's authored articles and book chapters on corneal cross-linking and is a co-inventor of CTAC, corneal tissue addition keratoplasty. Dr. Greenstein is a board-certified ophthalmology and refractive surgery and is a clinical assistant professor at Rutgers, New Jersey Medical School. He's a member of several ophthalmology societies and serves as the ophthalmologist for the New York Jets football team. Sorry about the Jets, Steve, but in any case, I want to have a warm welcome for Dr. Stephen Greenstein. Take it away, Steve.
Thank you. Yes, we're gonna get him this year for sure. So yes, thank you, Bill. So tonight we want to go over streamlining cataract evaluations to enhance your workflow, both pre and post-op, with the Pentacam AXL Wave. And what I hope to convey over the next 45 minutes or so is really both how the AXL Wave can help you improve your workflow for routine cases, for routine cataract surgery, but also how it can really help you evaluate some of the more complex cases that we see, where it takes the complex decision-making that is required and really breaks it down and makes it much easier and much more routine to be able to make the right clinical decision for our patients. So the AXL Wave really combines 5 elements in one device, and it is able to provide a wavefront guided autorefraction. It is able to measure higher order wavefront aberrations. It takes a retro illumination image. It's able to measure axial length, and of course it maintains the Scheimpflug imaging and tomography analysis, which the Pentacam has become so well known for. So really the key is that this one device combines what you would normally need 3 to 4 devices to do at an extremely high level. So it's able to provide both corneal aberrations with internal aberrations, taking both the front and the back of the cornea into account, with autorefraction. It gives a full Scheimpflug tomography analysis of both the back and the front of the cornea, which particularly in refractive surgery and corneal surgery, we've become so dependent on, and I'm going to show tonight how I think it's very influential and helpful in cataract surgery. And it can also provide axial length measurements now as well, to really give you a very high level and comprehensive exam of the anterior segment before doing cataract surgery. So I thought it would be helpful to start with actually our technician. This is one of our optometry interns who agreed to be the faithful subject, but really just kind of run through a video of doing a full sequence scan in real time for one eye. And it's a little disjointed. That's actually the upload. It's not, we did not speed up this video. And when you do a full sequence scan, you start with getting the aberration measurements. It's a little bit of a learning curve for your technician initially, just to get things into focus. But once they learn how to focus the instrument very quickly, the Pentacam will drive what direction you need to go in, as it does for normal Scheimpflug imaging. And then it will automatically capture the aberrations and the retro illumination image. You then move on to axial length, where you can let the device know whether this is a phakic, aphakic, or pseudophakic patient. It will take 6 measurements in pretty rapid succession, so it's excellent at keeping the eye in focus. And then we move on to the portion of the Pentacam which most people are the most familiar with, which is the tomography measurements. And this is the portion where all the Pentacams sort of work in a similar fashion. When you line it up with the vertex, it will automatically capture the Scheimpflug images in a rotating camera, and then you have all of what you need for one eye. So that video took about 1 minute and 15 seconds, which was the real time of getting an analysis of one eye. I will tell you that our Pentacam is connected to a server, which actually probably slows it down just slightly. So if you have it standing alone, it might work even a little bit faster. But essentially, to get the measurements that you would normally get from multiple devices, which would require you to bring your patient from room to room, type in their information multiple times, move them from device to device, 1 minute and 15 seconds to 1 minute and 20 seconds to capture one eye is a pretty streamlined way of getting pretty much all the data you need for the anterior segment. And really, once you have all that data, you can then generate this full sequence overview, which really captures in a snapshot a tremendous amount of data about the anterior segment. And I know a lot of work went into designing this overview. And while at the very first glance, it seems like it might be a somewhat busy picture of what's going on, once you get used to where things are located, it really does capture a lot of information on one page to allow you to make some much quicker decisions about your cataract surgery. So for example, if you're looking for aberrations and where are the aberrations coming from, there's a nice simulation to the left where you can see the top is the corneal front and back aberrations. The middle is the internal aberrations, with the bottom left being the total eye aberrations. And it gives you a really nice simulation of where the visual disturbance is coming from. And you can pull your view all the way over to the bottom right and kind of get a full measurement of those aberrations to help you whether you want to just decide on whether this patient is a good multifocal candidate, where normally you might have to look through multiple devices, multiple pages to make that decision. Sometimes you even have to come back to the room and tell the patients separately if you have to look some extra things up. This gives you a really nice snapshot about the patient's eye and what might be the best IOL of choice. So when we look at those simulations to the left, you can see that this is a case of early keratoconus. This is a young patient, so this is not a cataract patient. I use it to display that this patient had no internal aberration, so they have no lenticular aberration. And you can see in mild cases of keratoconus, the Pentacam AXL Wave is excellent at really defining where the aberrations for this patient are coming from. You can see in the simulation that the patient has significantly distorted aberrations in the cornea, in the lens relatively clear. And so when you look at the total aberrations, you can be fairly confident in this patient that their aberrations are coming from the cornea. Now, one word of caution with the AXL Wave, and this is something that is still being developed as we speak, as you move into more moderate and severe cases of ectasia in particular, where the posterior cornea is distorted, that can reflect itself somewhat on the internal aberration. So when we are dealing with more moderate and severe cases of keratoconus, as in this case, a more moderate case, the internal aberrations will reflect some of the posterior cornea. So this is, again, a 23-year-old patient with no internal lenticular aberration. But here you have to be careful about interpreting the simulation because this is still corneal aberration that is being displayed both internally and from the cornea as well. I know that the Oculus team is still working on this process, and hopefully with further development, as we even get to our more moderate and severe cases, we're going to be able to really fully pull out the corneal aberrations from the visual system. But going back to our original straightforward cataract patient and moving through the full sequence overview, what you can see is that the top right, you get an autorefraction which gives you an overall estimate of the refraction with both a simulation for nighttime with a dilated pupil and daytime with a more miotic pupil. We then have keratometry measurements, both our typical simulated keratometry of the anterior cornea, but also a total corneal power as well. So this could be very helpful as we're planning for toric lenses to see whether there is a posterior component to the astigmatism, and does that change the total astigmatism or the axis. And then it gives us kind of an overall analysis about the irregularity within the cornea. And the Pentacam is, and Oculus really does generate a tremendous amount of data when they do their analysis of any cornea. And in particular, when it comes to this, I really just want to focus in on one value, which is from the Bellin-Ambrosio display, and that is the D value. It's the D score that's created on the Pentacam. And anyone who's familiar with the Pentacam HR is probably familiar with the D score that's generated, but if you're not, the D score is a regression analysis which kind of emphasizes areas of elevation and areas that might be out of the norm for a pachymetric profile from the thickest to the thinnest points in the cornea. And it really kind of highlights how far out of the norm a cornea is, particularly to emphasize ectasia. So we use this in refractive surgery to try to screen or flag patients who might be at risk for developing ectasia. But the D score is a general kind of measure of ectatic irregularity in the cornea. So if you're seeing on your full sequence analysis a D score that is either flagged as yellow or red, you do know that there is likely some irregularity on the cornea, and you need to look more deeper into that. So this is our case, which is a very regular cornea, and the bottom right shows a normal D score. As you look at other cases where this is kind of a more of a form first, maybe a mild early keratoconus, so in refractive surgery, we would be very hesitant to do a LASIK on a patient like this. In this case, you can at least start to see that with the yellow flagging, this cornea is one standard deviation out of the norm. And so it's something that you need to consider in your IOL analysis and calculations. And of course, when we get to a truly keratoconic and ectatic cornea, which hopefully we would all recognize by topography, it flags in red, saying this is at least 2 standard deviations out of the norm. And usually if you're seeing a red D score, you are looking, and the patient has not had any previous refractive surgery, you are looking at a case of keratoconus, and you need to be mindful of that when planning for your IOL calculation. So this is a really nice and quick way with one value on your full sequence analysis to be able to kind of flag even an early keratoconus that you might not recognize immediately, even just with anterior topography that is available on other devices. Now, just to step aside just for a second from IOL calculations, but again, if you're familiar with the Pentacam HR, you might be familiar with the Bellin ABCD progression display. But this is a really nice tool that the Pentacams have and the AXL Wave includes, which also allows you to monitor for any type of progression if you are looking at a keratoconic cornea. So we use this primarily to monitor for progression pre or post cross-linking in our younger patients. But as we'll see in some cases that we look at later this evening, we can also use it to make sure that corneas themselves are remaining stable. And even though in our cataract population, we don't expect corneas to be particularly progressive, clearly a measurement of stability gives us even more reassurance that the measurements we're using are going to be hopefully stable over time. So the way that this analysis breaks down is it's really broken into 4 components, 3 of which are measured by the device, and the 4th component you have to add in. So the A is the anterior curvature around the 3 millimeters around the thinnest point. The B is the posterior or the back curvature around that same 3 millimeters around the thinnest point. The C is the thinnest location, and then the D is the value that you have to add manually, which is the visual acuity of the patient at each exam. We don't typically do that addition, but it certainly can be helpful if you want a quick way of looking at visual acuity change as well. And then the change that you see around that point in curvature, so moving to the right means the curvature has become steeper, is then evaluated against a normal population in green and a keratoconic population in red. And as the bars extend past the green, that is an indicator of possible progression. Those are confidence intervals, so 80 or 95% confident of progression if you're comparing to a normal population, and then 80 to 95% confident of progression compared to a keratoconic population. And the final piece that's been added to this is a post-cross-linking analysis. So you can, the blue is a population of patients and corneas that have already been cross-linked. And now you can compare 1 year after cross-linking and every subsequent exam to a post-cross-linking population to see whether or not there is an indicator of progression. And like I said, this has become very helpful. It makes it a lot easier for us to analyze progression in keratoconus for our patients who are young and post-cross-linking. But we do have patients who will progress even later in life, despite that being less of the norm. And as I said, before cataract surgery, ensuring that we have stability is really our most important parameter. And sometimes if we have to have our patients remove their contact lenses or particularly rigid lenses, we really do want to have a measure of stability before moving forward with our surgery. So then as we move along, we have some of our more typical measurements that we would see for biometry. So our anterior chamber depth, which can be seen both internally and externally, including the cornea, a horizontal white to white used in different formula calculations, an axial length with a signal to noise ratio, an anterior chamber angle, so you can see this and determine, at least with concern or not, whether your patient has a potential occludable angle. And then the chord mu and chord alpha, particularly the chord mu, which is somewhat similar to the angle kappa, where we look at the distance from the pupil center to the apex. And a larger chord mu might be an indicator for a patient who might not be the best candidate for a multifocal lens. So as you move towards 0.4 millimeters and above, we start to become more concerned that that large chord mu might affect centration of the visual axis with the lens and could create some more glare potentially or halo after surgery. So again, it's a quick parameter that you can very accurately see on the Pentacam to be able to determine whether or not your patient is a good candidate for a multifocal lens. And then of course, higher order aberrations, which we use in multiple ways, but again, as an indicator, particularly of whether or not our patients are good candidates for multifocal lenses, which will add aberrations to the eye. If you're seeing that the total higher order aberrations, which you see in the HOA at the bottom right, particularly on the cornea, so we're looking at the top portion of this, are also kind of becoming greater than 0.3, 0.4, certainly above that in 0.5, you really need to start to be somewhat cognizant of the fact that the cornea may be too aberrated to tolerate a further aberration from an intraocular lens. So it really gives us, with this visual sequence overview, a really kind of nice way of looking at a lot of different measurements very, very quickly to determine our next steps. One of the other nice things about the AXL Wave is we can kind of flip it around from our point of view and actually use it to educate our patients as to where their visual disturbance, where their blurriness in vision is coming from. And I do find this to be an extremely helpful tool in the exam rooms to really help our patients understand what's going on, why they need surgery, and potentially why we're making some of the decisions that we are. So this really focuses in a lot on that simulation of higher order aberrations for the patient. And you can see it becomes very clear to a patient like this, as I explained to most patients in layman's terms. We generally use 3 parts of our eye to see. The cornea is that clear window in the front of the eye. Everything comes through that clear cornea, needs to go through your lens. Also, it lines up on one point on the macula and the fovea, and that's what we depend on to get clear vision. And you can then clearly show a patient that your cornea, that clear window, is very clear, and you see with the simulation that you would see a very clear E with it. But internally, where your lens is located, that's where you're getting a lot of the blurriness of your vision. And you can certainly show them an OCT of their macula and say that looks normal. And so when we kind of put this all together, you can clearly see that your lens is what is contributing to your blurry vision. And if we then kind of focus in on that retroillumination image, so if we look here at a different patient who this happened to have been a post-LASIK patient. So if I just go back for a second, this patient was post-LASIK. You can see that very clearly in the axial topography on the bottom left. Again, a nice thing about the overview is that you really can kind of pick the portions of it you want to take a look at to be able to tell what's gone on previously. So this is a post-myopic LASIK patient. If you look at the elevation in the back, the thickness looks all normal, so nothing really concerning for ectasia. But this is kind of your typical scenario of a post-LASIK patient wondering why their vision has become more blurry. And if you go to the visual performance, you can once again use the same analogies to really show them that no, your LASIK is actually very stable. You look at the clarity of your cornea. What has changed for you is your lens internally. And we can even pull up a retroillumination image for them and really show them the opacity in their lens to really help them understand what is causing their blurry vision. So when a patient looks at this, they are very clear on what their problem is, what's going on, and what the next best steps are for them moving forward. So that kind of shows in general how we use the AXL wave from a cataract point of view, and particularly focusing on the full sequence overview. With the remaining time that we have, I want to dive into a few different cases to really kind of explore how we use the AXL wave to help us, as I said, sort of navigate through some of the more complex cases, but really are some of the cases that we do see all the time in our clinics, and really honing in on some of the other maps that you can then dive into even further to help us with our diagnosis and our treatment plans. So this first case is become kind of a fairly typical case that we all see in our offices nowadays, as our first wave of LASIK patients are becoming of age to develop cataracts. Now this patient is on a younger side, so cataract is definitely not necessarily the first thing on your mind. But this was a 50-year-old male who came to our office complaining of worsening vision in his right eye. He said it's been worsening over the past few years, and he's noticed that he can bring things really close to his eye again and see them much better, but his distance vision has really deteriorated in that eye. And even the close vision, he says, is not as good as it was just a couple of years ago. So his only really notable history is that he has a history of, a history of myopic LASIK that was done over 20 years ago at this point. And when we look at his refraction, left eye looks very solid, really no refraction to speak of, 2025 uncorrected, still 2020 with correction. But in his right eye, his uncorrected vision has dropped to 2400 with correction only to 2040, and a spherical equivalent now of -4 with a minimal astigmatism in his refraction. So this is something that we see in our office fairly now routinely. And again, this patient is on the younger side for cataract. So when you see a 50-year-old come in with this kind of refractive change, refractive is certainly on your, cataract is certainly on your differential, but might not be the first thing that you're necessarily thinking of for this patient. But as you pull in the full sequence overview, you can really start to get a sense very quickly of where the refractive problems are for our patient. So again, if we look at the simulation over to the left, we can see that the corneal aberrations, and then if you look at the bottom right, the number of corneal aberrations is just under 0.3. So really are not that significant. So there's not a significant, at least distortion of vision from the cornea and from the LASIK. And we are seeing that there is some internal aberration for sure that we're picking up on the overview. So here's where we can then dive deeper into our analysis of the cornea and really determine what the next best steps are for this patient moving forward. So this is a typical 4 maps refractive that we can pull up on our Pentacams. Again, for anyone who isn't as familiar with reading through these maps from the Pentacam, you can customize these maps in any way. So you can select a tangential curvature if you want. Instead of an axial curvature, you can do posterior curvature and anterior curvature. This is the most typical maps that at least people usually start with, which is an axial curvature map at the top left, an anterior elevation map at the top right, posterior elevation in the bottom right, and a corneal thickness map, which allows you to look at a corneal thickness profile in the bottom left. And this is usually a good starting point. You can then customize your color scheme. You can customize how detailed you want it. In general, at least in the axial maps, we try to keep it about at half diopter steps, but you can go lower than that or higher than that. And when we look at this map, this is pretty classic for myopic LASIK. We see a symmetric central flattening with surrounding steepening from the oblate cornea. There's really no significant anterior elevation. You can see a little bit of posterior elevation post LASIK, so small amounts of elevation that we see there is not particularly concerning, and a normal pachymetric profile for a post LASIK patient with the thinnest point being most notable in the center. One thing that is not yet available through Scheimpflug imaging on the Pentacam, but it is just a piece of the equation when you are looking at these patients, is epithelial thickness maps. So one of the things that we do know is that some of the refractive and myopic change that, and probably actually the most common refractive and myopic change that we are seeing long-term for our patients usually actually comes from epithelial hypertrophy. It comes from thickening of the epithelium over time, kind of filling in that oblate space. And this is a pretty typical amount of hypertrophy that we might see over time for someone who's had post-myopic LASIK. It does not explain a refractive shift of almost 4 diopters. Usually, if you see this, you'd be looking at a refractive shift of like a diopter or so. But it does, again, add to our differential and how we look at our post-myopic patient. So once we've determined that we do think, and through our exam, that we do think this is cataract related, and we can show that to the patient with the visual performance, the next step within the AXL Wave is the built-in IOL calculator that exists and can pull in all of the data straight into the IOL calculator on the device. So the calculator has a lot of flexibility to it. It allows you to put in pre-op refractions. It allows you to put in pre-LASIK keratometry if you do have those values, and it will use all of those things in variable formulas to help calculate your predicted refractive outcomes. And one of the really convenient things I do find with the IOL calculator is the tabs that you can see right above the IOL calculations. And with those tabs, it makes it nice and easy to kind of click through to what you're looking for in your IOL calculation. So it gives you 3 preset spherical options, which you can customize in any way, and you can change on the spot, so you don't have to use your pre-customization, but you can either choose to use a spherical calculation for one type of lens with multiple formulas, and then have 3 different lenses in sphere 1, 2, and 3. You could use multiple lenses with 1 formula and have 3 formulas in 1, 2, and 3. But it really limits the amount of clicking you need if you have some go-to particularly monofocal or even spherical multifocal lenses that you use on a regular basis without having to do a lot of clicking or changing. then has a built-in toric calculator, which can also adapt to different formulas using the keratometry values from the Pentacam to give you a toric calculation. And it has a post-refractive calculator as well, which, like I said, will do multiple different types of post-refractive formulas, mostly limited by how much data you then enter manually. So any of the data you get from the Pentacam is going to be used in any of the different formulas, but some of the data for certain formulas will require either a pre-op refraction or pre-op Ks, and if you don't have those, obviously you'll be limited in those formulas. And finally, it has a toric post-refractive calculator, where if you want to put a toric lens in after LASIK, you can do that with kind of a all-in-one calculation. So it really gives you a nice, easy way to click through the different types of lenses you might be considering for your patient and get to multiple sort of predictions and choices to choose from. So in this case, our patient is post-refractive. We were not looking to place a toric lens for him. So we used the post-refractive calculator. In this case, this was the patient's non-dominant eye, so we were aiming to keep him a little bit myopic for this patient, and we were able to select the lens that we wanted to place. Unfortunately, he did very well afterwards. In our next case, I think a little bit more of a typical cataract scenario, but still in the post-LASIK case. So this is a 77-year-old female who experienced worsening vision, typical distance and near change in both eyes. She had myopic LASIK also done more than 20 years ago, kind of a repeated pattern here. You can see that the patients that we're seeing, but overall, kind of a more typical cataract scenario. The corrected vision really doesn't improve in better than 20/40 in either eye. Minimal refraction, a little more astigmatism in the left than the right, but not much to note there. Again, we look at the full sequence overviews of both eyes. You can see that the cortical cataracts more in the right eye than the left. Some nuclear sclerosis that she had more in the right and the left, all contributing to more internal aberration in the right eye than the left. And we talk about doing a cataract surgery for this patient. What I want to focus in on is a little bit on the left eye, because now we have a post-LASIK patient with some level of astigmatism, and we really want to try to figure out whether they are a good candidate for a toric lens. And this can be very challenging, and if you don't have a sophisticated enough topography and really particularly tomography measurements, it can be a little bit hard and challenging to do. So if we again pull our 4-maps refractive, and here really particularly focus on that axial curvature map, we can see that what we're seeing centrally is a pretty regular topography. We are seeing it kind of line up on the flat axis along about the 145 degree axis. And then really what I like about these cases, and when you have a lot of data to work with, is you kind of get to see the reproducibility of data as you look through it. So if we then take our SIM-Ks and our total corneal power, we can see that in particular, most importantly, the refractive axis doesn't appear to change. So between our keratometry on the 4-maps refractive, which takes a wider zone than our typical simulated Ks, and then our more standard simulated Ks that we use for IOL calculations, as well as total corneal power, we're not seeing much change in the axis at all. Now, there is a little bit of a difference in the power, the astigmatic power that it's calling for, with some additive and more cylinder that we're picking up with the posterior elevation included. Sorry about that. And this is, where we have to make some decisions about what type and the power of the lens that we'll put in. But the nice thing in the calculator is we can actually use either one of these Ks to see how it changes our toric measurements and decide which way we want to place the toric lenses. In these cases, especially post-refractive, I usually err towards the side of lesser astigmatism correction. I'd rather keep them than flipping their axis, but our normal rules of preferring with the rule over against the rule and things like that always do factor in. And then you can pull up their auto refraction data which again, I just like to see refractions don't matter very much in terms of your cataract surgery, but I do like to see that when the refractive axis still lines up with our corneal axis, it's even more reassuring that the cylinder correction that we're getting does appear to be more in line. And then even our manifest refraction, which again lines up as well. So with all of the data that you're generating with the AXL Wave, we now can really strongly consider placing a low power toric lens for this patient. And in fact, with these patients, I will sometimes run both the post-refractive calculator, just because you can run more formulas. There are more formulas available in the post-refractive calculator, just to get a sense of sort of what is the spherical prediction in terms of power. And then, of course, more importantly in these cases, the post-refractive toric calculator, which then will give us not only the spherical correction, the power correction that we're looking for, but of course predict what we want from a toric power as well with alignment. And then post-op, we can take a look at our alignment and really get a nice confirmation on whether or not we have aligned our toric lens properly. So this is not the same patient. This is a demo patient, but you can see that if you get a really good dilation with our retroillumination image, we can see the marks of the IOL and the axis, and you can actually take the blue line that you see and you can kind of rotate it around until you get those to capture the marks of the lens, and then see what axis your lens is truly aligned on. In this case, it's about 90 degrees, and compare it to where you want it to be pre-op to ensure that you really do have a good alignment. This is incredibly helpful, of course, if you're wondering if you're seeing residual astigmatism or especially with a change in axis, are you off on your alignment, and then can place that data into our alignment calculators to see whether or not you want to rotate the lens. So in our case, this is the same patient post-YAG, so this was a few months later, but we run that alignment and we can see that we wanted to place the lens at 58 degrees. We're measuring it with the IOL post-toric IOL calculator about 55 degrees. So we're about 3 degrees off. I am satisfied with that placement, and we know that we have a adequately placed and hopefully good post-operative result. The full sequence overview, as we just saw, and the AXL Wave with the can help us with the post-op toric IOLs, but it really can help us post-op with a lot of different things that we're seeing and allow us again to make quicker and more accurate decisions about how we want to move forward, and also help educate our patients on what's going on. So this was another patient of mine, 76-year-old female who had I placed a multifocal lens in her left eye, and 2 weeks later placed the multifocal lens in her right eye. And then she said she's about 2 weeks after surgery in the right eye, and she said the left eye was doing great, everything was perfect almost from day one, but the right eye really isn't as good, and she was obviously concerned as to why. And the truth is, all of our hearts are pounding a little bit at this point because we put the multifocal lens in. I mean, she did well in one eye, so there wasn't necessarily a reason to think that she wasn't going to do so well in the other eye, but is the lens off center? Is it, is there something wrong with the lens? Do we have to, what is it that is contributing to this problem? And we want to be able to project confidence to our patients that we really can understand their problem and then help them get to the endpoint that they desire. So clearly, if you look at the full sequence overview for this patient, you can see that the lens appears to be well centered. And from an internal aberration standpoint, if you look at the simulations on the left, there isn't much internal aberration there at all. Her cornea, on the other hand, looks like hell. Her cornea looks terrible. And if we look down at the axial curvature map, we can see that there's a lot of irregularity there. So did I miss an irregular cornea? Did I miss a early keratoconus in one eye and put a multifocal lens in there? Hopefully not, because hopefully we've looked at the full sequence overview beforehand to be able to rule that out. but why does her cornea look so terrible? And we can then actually use what we, again, people who are familiar with the Pentacam are going to be more familiar with, but you can take whatever map you want and compare it to any time frame you want. So in this case, I took her axial curvature map from pre-op and compared it to where we are today. And we can see that there is a pretty significant flattening right in the center of her cornea. If we look at the difference map on the bottom right, which is giving kind of like a corresponding steepening right below that. So there is certainly central irregularity that which did not exist before the surgery. And now we have to figure out why that is the case. So again, this just emphasizes sort of that difference that we're seeing pre and post-op, which is very easily, you can easily analyze it with the maps that are available on the Pentacam itself. And in this case, it turned out that she had a very, very dense SPK centrally, which is really a reaction to the preservatives in her post-op drops. And that was what was causing all of her irregularity. So even if you could see that and do that clinically without all of the different measurements and the simulations for yourself, it does give some confidence as the clinician that you are definitely focusing on the right area of problem. And again, it allows you to train and teach your patients as to why and what is going on here. So if you take the visual performance and you show them, well, this is kind of your visual performance. Your lens looks good. There really isn't much aberration there. But your cornea really is where you're getting a lot of blurriness. And when we look pre-op, that wasn't there. So if we look at your simulations pre-op, your cornea looked pristine. It looked great. So now we come up with the plan and we say, well, we're going to stop your drops. We're going to stop the drops that have preservative. We're going to give you only preservative-free drops. And we see this patient back 1 month later. She is obviously telling you already that her vision is better, but you're seeing it and you can show them their progress with the visual performance display. So you can show them, look how much better your cornea has now gotten. This is why your vision is getting better. And now, as long as we keep you sort of on this preservative-free regimen and eventually off, hopefully, topical therapy entirely, our anticipation is that you are going to do equally as well with your right lens as you are doing with your left. So moving to a little bit, again, in our post-LASIK theme, but a little bit of a different case. This was a 67-year-old who we saw in our office. She was actually referred from an outside ophthalmologist who had called me and let me know that he had been sent this patient for cataract surgery, and really in a very important way had identified that something was off, and that's really the most important thing to identify at first, and he wanted further workup. But essentially that when he was looking at the keratometry values on his biometer, topographer, and some manual keratometry, which is impressive, that was done, nothing was really adding up. All the keratometry values were kind of all over the place. And you can see both with multiple devices, you're trying to get things to sort of come together, to sort of jive together. And so that can be somewhat problematic if you're using different devices which use different techniques to be able to measure these different measurements. Sometimes that can be a problem. But also you can just have, based on different corneal measurements, some differences in your keratometry readings, anterior, posterior, the things that we've talked about. So when the patient came in, she had said that her vision in the left eye had gotten worse. She said that it was good after LASIK, but it's been worse in the left eye for a while. She didn't really have a good reason why, but was told that she had cataract, was referred to the ophthalmologist who sent her to us, and really assumed that the vision was all cataract related. And if we pull up our visual performance display, so one of the things here is there is both corneal aberration in the simulated profile and internal aberration. But remember, if there is irregularity, particularly if there's any posterior irregularity, this is something that you have to be mindful of. And if you go to the numbers themselves on the aberration profile, although they're hard to see, there's almost one in higher order aberrations, 0.97, and really only 0.4 in the total eye. So the cornea is clearly contributing significantly to this patient's aberrations. And we can take a look at the bottom left, and you can see there is definitely some irregularity in that cornea, and we have to figure out why. So we can then look at a map that exists already, which is called the Cataract pre-op map. And the one thing that this adds to the equation, which isn't on the visual performance display, is you can look and get this PNS value down in the bottom right. And it's a bit of an estimate. It's an estimate of the densitometry of the lens. So it can kind of give you a little bit of an idea of, are you dealing with cataract? Are you dealing with some density in the lens? And in this case, it's giving the densitometry of the lens a 1, which is basically very early nuclear sclerosis, but nothing major to speak of. So putting that together with the data you have, even before seeing the patient, you can say, well, the lens doesn't seem to be at least a major contributing factor here, because the densitometry of that lens is not particularly high. So the internal aberrations that you're seeing are probably not very related to the lens, and now we really want to focus in on the cornea. And so when we pull up our 4 maps refracted now on the same patient, we look at the right eye, and the right eye has a fairly typical post-myopic treatment. It does look like maybe it's a little bit decentered, and this was probably early myopic LASIK where the smaller zones could contribute to that. Definitely some irregularity in the right eye, but you can clearly see in the left eye that there is significant irregularity with inferior steepening and central and superior flattening. So it's definitely possible that we're looking at an early ectasia here. This wasn't so clear cut because there isn't really very significant posterior elevation in the area of steepening, which we would expect. So I was really trying to drill down with the patient as to when this kind of visual change happened. But at a minimum, we can certainly say that what we're seeing now is visual change that does appear to be from the cornea. It appears to be that the aberrations of the cornea are what is contributing the most to this patient's visual problems. And when we then, I did have the patient, I'm fortunate to work with Dr. Gellies here, who is an expert contact lens fitter. And so I did have him do a over-refraction, RGP over-refraction for our patient. And her vision was actually 20/20 with the RGP over-refraction. So we're getting even more confirmation from what we saw with the AXL wave that this is really a cornea problem. This is not a lens problem, even though this patient is of cataract age. And we actually decided not to do cataract surgery for this patient. We did topography guided PRK for this patient. And with the ablation profile that you see above, we were able to take that very irregular central cornea, make it much more regular, and much more refractable. And when we refracted her 3 months later, she was 20/30 uncorrected, 20/20 corrected with a bit of mixed astigmatism and much less anisotropia. So essentially, she can now wear her glasses with adequate 20/20 vision, really excellent 20/20 vision in both eyes. So the key point here is what the AXL wave allowed us to do by taking such detailed measurements of the anterior segment is look at a complex case of irregular cornea and first pause and say, this is definitely different than a routine case, and then try to drill down and see where is the problem, where is the refractive problem coming from, in this case, the cornea, and then address that corneal problem and really avoid doing cataract surgery, at least for now, for this patient entirely. And in fact, if we had done cataract surgery for this patient first, we really would have been in a much worse situation, because clearly our ability to predict the refractions for a patient like this decrease. We might have thought to put a toric lens in a patient, with astigmatism, which would have probably turned out to not work particularly well with the irregularity. And then we'd have to deal with that sort of a exchange. And no matter what, at the end of the day, we're going to have to deal with the cornea at some point to give this patient adequate vision. And we were able to do that beforehand and really address this patient's true visual problems. And just to wrap up with kind of a final case here of true, more clear-cut ectasia. But again, here we're seeing in that axial curvature map on the bottom left, it should kind of jump out that this patient does have some level of irregularity. We now have a posterior elevation in the middle image that you see at the bottom, which is a really nice extra feature of having tomography, because when you see some irregularity on the anterior curvature, you're never totally sure what's contributing to that until you both examine the patient. But posterior corneal elevation really helps you kind of identify that you may be looking at early ectasia. In this case, although post-LASIK, the bad analysis is not as useful as a virgin cornea and eye, but certainly is at least flagging that something irregular is going on here and you need to take a deeper look. And certainly this patient does have a post-LASIK ectasia. Very important to identify this before you're going to move forward with cataract surgery, both from a planning purpose, from a counseling purpose as to what your where you think you can get to from refractive outcomes. And these are all really important things to be able to talk to your patient and tell your patient about beforehand, so that you're not catching up post-op with somebody who's upset with their visual result. As we kind of talked about at the very beginning, even though these patients are older and we don't expect their corneas to change very much, with ectasia after LASIK, we are not as confident that that's the case. And we've done a lot of research and analysis on post-LASIK ectasia showing that those patients do tend to have progression much later in life. There's really no point in time where we can completely tell a patient post-LASIK that they're not going to have progression, but we're able to, in this case, at least look at the patient's cornea over a 6-month span and see that the curvature in the front, in the back, and the thickness is all very, very stable. And this gives us an extra confidence to now move forward and say, well, from a corneal measurement standpoint, our numbers are reproducible, they're not changing, and now we're going to use our IOL calculator to predict what to do for this patient. In this case, I did put in a toric lens, and although it's a little hard to see on this image here, we are able to then analyze the location of the lens post-op and make sure, again, in this case, we're about just 3+ and change degrees off. And this patient also turned out to be very happy with their vision, and we were able to account for their ectasia with the proper lens placement and confirm all of that afterwards. Again, this was going to be for patients near eye, so all had worked out well. So I'm hoping over the last 50 minutes plus or so that I've been able to kind of show how the AXL Wave can streamline your cataract workflow. It takes a lot of measurements in a relatively quick time frame for both eyes. It really gives you an incredibly detailed analysis of the cornea, which is helpful from a refractive surgery standpoint, and cataract surgery is now a refractive surgery. So it really helps you best analyze what is best from an IOL platform for your patient, how to counsel your patient about their diagnosis and the surgical plan, and also how to evaluate some of your cases post-op, either because you just want to confirm placement of the lens, or you're having, and the patient may have visual complaints, and really be able to identify those and confidently treat them for excellent visual results. So with that, I will turn things back to Bill, and thank you for your attention.
Wow, Stephen, what a great series of cases. Each one more interesting than the one before. It's really fantastic. We do have a bunch of questions, and so let me ask you something that you said early on, and maybe you can elaborate a little bit on it. You talked about the different K readings and the total corneal refractive power, the TCRP. Can you just tell us, when you are using or choosing the toric IOL and you look at the TCRP, how does it change whether you're going to go up or down, or does it change? And tell us a little bit more about what you look at and how you utilize it.
Yeah, so I mean, the first thing I want to look at is how do things how complementary are those Ks? So if there is a very large difference, let's say over, a half a diopter, and it can be much more in obviously keratoconus patients, of difference between the total corneal power and the SIM Ks, it's at least a flag to have to think twice about whether you're going to use a toric lens, number one, and if you're going to use a toric lens, what power do you want to use with it? So the first thing I'm looking for is just kind of symmetry between the values. And usually if you're kind of under about a half a diopter in power, and if your axis is relatively lined up, let's call it within about 5, even 10 degrees or so, depending on how what your goals are for the patient. That's the first just piece to, it's almost a screening tool to be able to say, I want to actually take a pause and kind of figure out what to do for this patient. Past that, I mean, I think the thing you have to be most conscious of is which formula you are using. If you're using a formula, most formulas assume the posterior curvature of the cornea. So you do not want to use your total corneal power in a formula that's already assuming posterior curvature. That is going to get a very bad result. So you need to make sure if you're going to use total corneal power, that you are putting it into a formula that asks for what that number is, to make sure that you get an accurate result. And again, I find in general with formulas in complex cases, you want to get a bunch of different measurements. So if I'm looking at a total corneal power and the predictive axis and power with that, and then with the SIMKs, I want to see, do they line up? Is the power similar? If they're not, I usually will err on the side of not flipping their axis. So if one suggests that we're going to flip their axis, I will kind of back off towards the one that suggests that we won't, and obviously not overcorrecting. They're still, with that flip. So that's kind of how I look at it. I think it's more of a matter of being careful of the formulas you use with it, and also just using it as a barometer for whether you should put a toric lens in and what the power should be.
Excellent. So no double dipping.
Right.
Excellent.
Absolutely not. That's the key.
So we've got a bunch of questions on high order aberrations. I'm going to try to put them together. And so when you're considering either a diffractive multifocal or an EDOF lens, how do you assess the high order aberrations? Do you look at the total high order aberrations? Do you look at specific ones? And does it make a difference whether it's an EDOF or a multifocal IOL?
Yeah, so so yes to all the above. The key number one is we're really concerned about corneal aberrations. So once we're removing the lens, as we all know, the internal lenticular aberrations are going to hopefully be gone. So we're exclusively focused on the corneal aberrations, which is why a device like the Pentacam AXL Wave is so important, because it is when you're looking at aberration profiles, you need to make sure that the device you're using is showing you the specific corneal aberrations. Because in a cataract patient, if you're looking at total aberrations, likely on a normal patient, most of the aberrations you're seeing are from the lens, and you will definitely tell patients who are candidates for multifocal lenses that they are not, because of their aberration profile, and that's incorrect. So the first thing is that you need to make sure that you're pulling out corneal aberrations. The nice thing again about the AXL Wave, although as I said in more severe cases it still has work to be done, it is taking into account the front and the back of the cornea. So you really are pulling out all of the corneal aberrations to really get hopefully what is the most exact measurement to determine what lens to put in. With multifocality, at first, I'm most concerned about the total high order aberrations in the cornea. So I want to see, is that number generally high? Usually once it's past about 0.3, you need to start to think it's getting high. Past 0.4, definitely getting high, and certainly above 0.5, absolute no-go. I would say if the corneal aberrations are above that for a multifocal, and you really at that point need to figure out where are their aberrations even coming from. Then I kind of drill down to the specific aberrations, coma and sphere being the two most important. Trefoil is there as well, but less important of the three. High coma aberrations is also kind of a no-go in the multifocal world, category. If they have high coma aberrations, they are likely not going to be happy on the multifocal side. Spherical aberrations are a little bit different. If it's specifically spherical aberrations, I'm particularly concerned about on the EDOF lenses. So because most of the EDOF lenses work in some capacity by increasing negative spherical aberration, that's how they work. I do look at the corneal spherical aberrations to determine whether or not they're a good candidate for an EDOF lens. So for example, a post-hyperopic LASIK who might have higher order aberrations and particularly high spherical aberrations, but not high coma or trefoil, and high negative spherical aberration, I might shy away from an EDOF lens because I'm going to be compounding the negative spherical aberration there. But on a post-myopic LASIK and an oblate cornea, which maybe has low trefoil, low coma, but a high positive spherical aberration, I'm more inclined to use an EDOF lens with negative spherical aberration because I think it's actually going to work better to extend their depth of focus. So in those ways, it can be extremely helpful in terms of picking IOLs.
To piggyback this question, another question that is related to it, and you kind of touched upon it a little bit, is while Pentacam measures the back surface of the cornea, specifically the high order aberrations, how clinically significant are the HOAs on the back of the cornea? Do you find them to be clinically significant?
So it's not so much about their clinical significance. I mean, because once you're dealing in the keratoconic cornea, you know, the clinical significance of it is that they're not really candidates for multifocal lenses. So if you're seeing high levels of corneal aberration, which you're going to likely see more on the front than you even are on the back, you know, the idea of putting in a multifocal lens or an extended depth of focus lens is really counterproductive for a keratoconic patient. So I don't see it influencing as much the lens choice. Where I see it being very helpful, though, is in our decisions about what is the problem for our patients. And it is still a challenging problem because you can clinically look at a patient in the slit lamp and kind of see that they have potentially early nuclear sclerosis, which could certainly shift their prescription myopic. They could also have a steep cornea from keratoconus, which is going to make their prescription more myopic, and keratoconic patients are somewhat notorious to be able to measure their prescriptions to begin with. So you can measure some increased myopia and have a challenge is to figure out, well, how much is the lens contributing to their myopic shift or their visual distortion. And being able to pull out the corneal aberration and really kind of look at the lenticular aberration alone gives you more confidence as to where their problem is coming from as they're developing early cataract. And so in early keratoconus, I think the AXL Wave is doing a really good job with that. And I'm very hopeful that as the software continues to develop and it continues to refine for more moderate cases, it will be very clinically helpful for us in keratoconus.
Stephen, I have one final question for you, and it's something that we didn't talk about tonight, but the question is, when considering a multifocal or EDOF IOL, do you look at cord alpha? And if you do, what do you look at?
So I don't really use cord alpha that much. I really use cord mu and kind of angle kappa. That's my main kind of parameter I look at. And I use about 0.4 on the cord mu as kind of a general kind of, it's getting large and it's not. I'm certainly more concerned about it with multifocal lenses than with the EDOF lenses. I think the EDOF lenses have a much better tolerance of a higher angle kappa and a higher cord mu. But that's really where I focus more than the alpha, which is the corneal center to the apex. I think the pupil center, at least for me and what I look at, tends to be more relevant.
Excellent. Stephen, thank you so much for sharing your knowledge and these great cases. And thank you so much, everyone, for attending tonight. And I wish everyone a great rest of the week. Have a great evening.
Have a great night.